Good morning, everyone. I'm going to have the pleasure of introducing our speaker this morning because he's an old friend of mine. So it gives me a great pleasure to introduce Nathaniel Hupert. Nathaniel and I have had very parallel lives for probably 30 years in terms of where we've worked. He's currently an associate professor of healthcare policy and medicine at Weill Cornell Medicine. He's a senior medical advisor, Division of Preparedness and Emerging Infections at the CDC. He's also a permanent member of the National Academy of Sciences, Engineering, Medicine Committee for Evidence-Based Practice of Public Health, Emerging Preparedness and Response. And I have known Nathaniel, who I always called Nate, but I think he's Nathaniel now. And I used to be Teddy, and now I'm Ted, so I guess that's what happens. We went to college together, we went to medical school together, and then we came to Cornell together, and we were really friends throughout, which has been wonderful to have someone who you know and respect and has been leading a parallel life. And you're also from New York, right? You went to Stuyvesant, didn't you, Nathaniel?
Oh yeah, I'm from Tribeca.
Right. So, and we both grew up in Manhattan as well, so that was great. And then he went on to do an MPH at the Harvard School of Public Health and trained in Pittsburgh. And he was one of the first phone calls I made because I've always known that his specialty here at Cornell is disaster preparedness, and in particular, responses to pandemics. And so when this all happened, I was like, holy moly, like, Nathaniel must be working overtime right now. I wonder what's going through his head. So I gave him a call and we talked a bit, and then I said, it would be great if you could give us a grand rounds because I'm sure everybody would love to hear what you're thinking. And so it gives me great pleasure to introduce Nathaniel Hupert.
Thanks, Ted. I should say thanks, Teddy. But I think I always called you Ted. It's a pleasure and an honor to be here. I'll say that we have had parallel lives, except in one respect, which is that I'm really bad at writing papers. So I'm lagging behind you a little bit on the academic food chain, but trying to catch up there. This has been a crazy 5 months. For those of us in this line of work, we really got worried in December. It's turning out now that was for good reason, that the earliest cases, it turns out, were probably traveling around the world in December, probably even November, possibly back to October. But I wanted to give everyone here just a really lightning update on where we've been with modeling and where things might be going. And the picture that you see here is from around the 1840s. It was from the person who thought that Malthus, who famously predicted that we'd all run out of food, was wrong. And he was wrong because that what's called there on that image logarithmic upward, simply upward tracing curve was inaccurate, and that the logistic curve, which has that asymptote, was more accurate. And it turns out that a lot of early modeling about this pandemic has made this similar type of error of thinking that things would simply go up when in fact they were going in a different direction. So I just need to have this disclaimer. Everything that I'll be saying now is my own opinion. It's not the opinion of any of the institutions for which I work or with whom I'm affiliated now. And I've thrown in the University of Oxford there, and you'll see why in a little bit. So I'm just going to briefly go over the epistemology of modeling, how we know what we know, and then where we are now, get you familiar with some early projections that we made, mostly using this thing called the Cornell caseload calculator that I slapped together early on, and then from that, transitioning to why COVID really is not like the flu. And I think we now have a really good understanding of why that's the case. And then a change of perspective that we shared with Governor Cuomo back about a month ago, and some current modeling that we're doing. And then finally, what's missing. And as you may know, there are a lot of questions about who's really being most impacted by this. So the policymaker faced with a curve like this asks the modeler, where's this curve going? This is from the Spanish flu, and you can see in the dark, in the solid black line, that's New York. And this has personal relevance for me because, in fact, where that curve was going in February of 1919 was 186 Throop Avenue, where my great-grandmother, Mary Siegel, lived. She was 32 when she died after a 4-day illness of bronchopneumonia. That's her. And so she was a classic case of pandemic influenza, young, healthy, 2 daughters, and died within 4 days. That's not what COVID is looking like. But to figure out what COVID is looking like is quite complex. So this is a picture that my great and sadly now former colleague Babak Pourbalal put together. Start at the lower left-hand corner, you'll see lab-confirmed cases. Those are the red dots. And then you'll see, as you go counterclockwise, symptomatic and reported cases, and then to symptomatic cases, infected cases, all cases, and then the whole population. And you can see how underneath this blue ball of the entire population is this tiny number of lab-confirmed cases. Figuring out what the relation between the red cases and the blue cases is quite complex, and that's one of the tasks of models. So where are we now? This is straight from the New York City GitHub site and from their website, and also from the state's New York City data that's called HERDS. Funny side story, back after 9/11, a couple of days later, Mark Callahan and I, he was my old boss back in the Department of Public Health, put together a sheet of paper, just 1-page questions that we wanted to ask New York Presbyterian Hospital managers to see what was going on. We handed it to Elliot Lazar. We called it HERIS, the Health Emergency Information Response System. Elliot wound up using it. He was the former director of emergency preparedness for NYPH. And then he handed it to the state, and the state eventually turned it into this system that's now called HERDS. And so you can see we've got 44,000 hospitalizations, roughly, 14,753 confirmed deaths. There's an additional number of probable deaths. And you can see these are census data, so peaking, according to HERDS, at about 12,000 hospitalizations, and peaking in the ICU a little bit over 3,000. There's a problem, though, which is that the HERDS data, which is reliant on hospital self-report, is different from the city data, which is reliant on the HERDS data, but also on the syndromic surveillance system and other sources. And in fact, if you total up hospitalizations from the beginning of this pandemic to now, the difference between the two is over 10,000 cases. So right off the bat, we have a difficulty figuring out what's going on. And the New York Times, of course, has done a great job visualizing what's going on. And so you can see some of these pictures. One thing to note is how patchy the incidence is in the different boroughs. We'll get back to this. The other thing to note is that New York is really an outlier, both in the US and also globally. So any conclusion that we draw about, for example, second waves in New York City doesn't necessarily apply to other locations in the US or to other locations globally. And then we have this thing that, again, was pointed out in the Times and in other places, this mystery of excess deaths, where New York City is really a leader. And that's what I mentioned before. The city is now trying to accommodate this fact that we don't really know how many people have died of COVID. So in the face of these difficulties with data, we have to triangulate, and we try in many different ways to figure out the critical things that we need to know about the disease in order to make reasonable, logical projections. The first is we need to know how many infections, how many hospitalizations, and how many deaths. But hospitalization data is subject to a lot of wiggle. So for example, it might be that people are not coming into the hospital or not being admitted. There's this new term, nosophobia, fear of going to the ED. There's difficulty with transportation during the lockdown. In addition, we know that, for example, in our hospitals, we started raising the admission bar. For example, decreasing the oxygen saturation level that was permissible to have someone be sent back home as opposed to come in. And that was sort of an effort to conserve the commons. In addition, we could think that perhaps people might have, because of hypochondria or other reasons, been more likely to come to the hospital. And then later on in the course of this disease, there was an awareness that patients who looked fine could potentially crash very quickly within hours of coming in. And people were definitely coming in with more severe hypoxia than appeared from their clinical presentation. So back in, you can see the date of this slide is March 10th. So on March 10th, this was the sort of information that we had. We knew about Wuhan. This is the Hubei daily change in admissions, what we call the daily delta. We saw Italy happening, and then we were sort of tracking Italy. And when I put this together initially, I decided to use some gamma distributions. That's a simple mathematical distribution that starts at 0, reaches a height that we can call the mode or the mean. It's the same for the gamma. And it turned out that the Wuhan data actually matched this pretty well. Now, whether that was because of the lockdown in Wuhan or whether that was a natural feature of the disease was unclear at the time. We weren't sure that we were going to look like Wuhan or any place else was. And so we chose a bunch of different curves to experiment, and we wound up putting these into this thing that was called the Cornell caseload calculator. It turned out, and of course we didn't know this was going to be the case when we started, that New York City actually did fit a gamma distribution almost perfectly. And again, whether this is due to natural factors having to do with the disease traveling through a population, or that inflection at the top was due to the lockdown, is really unclear at this point. We don't know scientifically what the reason for this is. And this certainly is not what other places have looked like. For example, Stockholm, which has an almost identical upswing when you look at it in terms of per population hospitalization, has a very different downswing. It's stayed up now for a couple of weeks after reaching that peak. So we put this all into a spreadsheet. This is sort of my forte in terms of what I've been doing with the CDC for the last 20 years. CDC favors spreadsheet-based models because that's what public health people use. They don't use R as much as they use Excel. So we created this spreadsheet, and this actually wound up leading to this thing called the C5V model, the Cornell COVID caseload calculator with capacity and ventilators. We've had it up on our website now for a couple of weeks. It's had a lot of downloads from a lot of different places. And it was based on the planning scenarios that the CDC gave out. And you can see that this was the first version of this way back in February. So CDC was thinking about this from the very start, partly because our experience at CDC had been through the H1N1 pandemic, the cholera outbreak, and then Ebola, had been that it was difficult when all the different modeling teams in the country were doing their own thing. So CDC decided to set out these 4 scenarios and give a whole bunch of information, mostly based on flu, in terms of different types of infectivity, different types of asymptomatic contributions, et cetera. And so these were the starting points. In addition, we had some other data. For example, the Diamond Princess. My colleague Carter Meacher was very active during January and February getting these summaries out to a lot of us. So we had a sense of what the case fatality ratio for that unfortunate cruise ship was, what the critical illness ratio was, what the total attack rate was. And some of these numbers obviously were very, very worrisome. So initially we started to generate what according to the CDC categories were these mild scenario estimates and severe scenario estimates. This doesn't mean mild cases or severe cases. It's the overall population prevalence of disease at the end of the day that these 2 terms refer to. And you can see this is from March 3rd, in my earliest projection using these modeling parameters and this particular model. And when I say model, I mean fitting it to a curve. with no generation of the curve internal to the model at all. I'll get to that later. So these very simplistic estimates gave us a range of between 28,000 and 109,000 hospitalizations. And as I mentioned, right now, sitting past the peak, but still not done, we're at 44,000. So this effectively got us in the ballpark. When that model continued to run, we could break it down into general medical admissions and critical care admissions, and we could actually think about what the peak. Now you saw that New York City actually fits this 30-day mean gamma distribution really beautifully, and you can see that in the mild case, it predicted 779 cases on that peak day and 144 ICU cases on that peak day, and these weren't far off, it turns out. But there's a problem. The problem is that if you really look under the hood, the data looks more like this than like a smooth curve. So this is, for example, ICU admissions across the city. And if you break it down even more, it turned out that we were having a whole bunch of differently shaped epidemics going on in New York City alone. And really, at this point, it's an aspiration of mine, but no one has really modeled this on a borough by borough level, but it clearly needs to be done. So for example, you can see this spike in Queens that was followed by a spike in Manhattan. These are complex data points, partly because of the disease and partly because there were transfers going on, as everyone knows, between different hospitals, certainly later on in the outbreak. So we don't really have a natural picture of what's coming into the emergency department or into the ICU. We have a managed picture. Later projections, again, this is all the earlier work that I was doing. So this is May 11th. This is March 26th. And this is a publication that I was a part of with the Task Force for Mass Critical Care. They asked me to estimate what was going on in New York, and I gave them this. I said, if you think that 7% of all people who are affected by this will require hospitalizations, you'll wind up with 88,000 total hospitalizations and 13,000 ICU admissions. And I have to say, when I was writing this, we had not even a tenth of that. And it seemed quite unrealistic, but I went with it. What I'll have you focus on here is that at the time, we were thinking that 7% of all people were requiring hospitalizations. And it turned out that just about the time that was published, I and a bunch of colleagues were having a bit of a sea change in how we were thinking about what was going on with SARS, the virus, and COVID, the disease. Initially, people thought that this was an event that was affecting a very large number of people over a fairly long period of time, with a very large fraction going to the hospital. That has now, in some places, started to be called the old paradigm. And that paradigm is very importantly prevalent in critical articles and models that have influenced national policy. Some of them, like the IHME model out of the Gates Foundation and University of Washington, have updated their views. Others have not. Critically, the NYU and Columbia University projections for the city of New York very much hewed to this old paradigm. And I actually broke away from that group at the end of March because I was influenced by some new data that suggested a new paradigm, namely an even larger number of people infected over a much shorter period of time with a much smaller fraction going to the hospital. And so this image gives you a sense of what these two things look like and why, if you just look, for example, at hospitalization data, you could have difficulty distinguishing the two, namely that the two would produce the same number of hospitalizations, except it would be very radically different what was coming next. And in fact, just at the moment that I realized that I firmly believed the fast growth model, as it's called, New York City was sort of reaching its peak. And at the same time, other modeling groups were forecasting much worse numbers of admissions on the horizon. So it turns out now, hindsight is beautiful, that even though, as I showed you, that Hupert curve looked like a nice 30-day gamma distribution, re-estimates of what was going on in Wuhan actually support this fast growth hypothesis, because it looks like there were actually many more individuals infected, and the hospitalization was, if anything, a lagging indicator of how that infection was going on. You can see that in the estimated gray cases compared to the blue cases that were observed, that were the red line that I showed several slides back. And it turned out that if you thought through the data that was coming in, the 1 to 2% hospitalization rate in New York actually fit the data much better. Really, though, there were 3 sources of evidence for this new paradigm that I could find and that my colleagues could find. One was using the available NYC syndromic surveillance data. It was just abundantly clear what was happening, except it's very difficult to find this data on the New York City Department of Health website. Second, again, as I mentioned, I had some mathematical colleagues, one from Penn State and one from Montana State, with whom I actually was connected through Colin Parrish, a virologist up in Ithaca, and we wound up creating some much more robust calculations. And then there were other sources of data that I'll mention in a minute. This is free for anyone to use. It's available on the web. As I said, it's very difficult to find, but you can scroll back in time, and oops, I see that this is actually mislabeled. This is 2017-18. You can see that from the x-axis there. And this is a typical indication of syndromic surveillance from New York City's 53 emergency departments for a typical flu year. It takes about 4 months from the start to the end. This was a system that was created after 9/11 to detect bioterrorism events. You can see this year that we had our typical flu year. That's what's not labeled. And then where it says start, we have something extra. And that turns out to be almost for sure the COVID outbreak in the city. And you can see that it rises up and then it goes back down. And it takes 1 month. Using that data, which is actually all downloadable on a daily basis, you can figure out what the daily excess influenza-like illness is. That's the 45,976 for 2020 versus 2016 through 2019. And you can use a published multiplier, which is 60 cases in the community for every ILI, influenza-like illness case in the emergency department, and come up with a number of 1.2 million people who probably in their homes were symptomatic with an unusual influenza-like illness syndrome at the time that COVID was spreading. And this translates to about a 15% fraction of the city. So my colleagues, Alex Washburn and Justin Silverman, Justin's an MD PhD. They both did their graduate work at Duke. It turned out that Justin's PhD was doing just this sort of calculation. And so this is one figure from a paper that we're now in second review on at Science Translational Medicine. And using a much more sophisticated approach, Justin figured out that there are probably 1.3 to 2 million cases by the 4th of April. And this is the paper. And so if you put that together with the finding in late March to the beginning of April, that about 15% of women in labor and delivery, both at New York Presbyterian hospitals and also at the Brooklyn Hospital Center, were positive for active virus, even though they were almost universally asymptomatic. Combined with the finding in later April that 22% of New York City was positive for antibodies. And this was, as I'm sure you know, standing in front of a grocery store and getting all people 18 and older to answer some questions, and if they were willing to get an antibody test, that turns out to be about a 40% prevalence by mid-April of infection in New York City. And if you take these numbers and you do some calculations, you wind up with infection hospitalization rate of about 1.3%, a case fatality rate of about 0.54%, and a hospitalized mortality rate of about 40%. And so if you compare these back to influenza, it turns out that that IHR, the hospitalization rate, is about 2/3 of a bad flu year. And so this gets back to the point of, why weren't people coming in? And I think that we have a lot of reasons for that. The case fatality rate is about 3 times that of a bad flu year. And the hospital fatality rate is also about 3 times worse than a really bad flu year. And so if you put all that together, this is why why COVID is not like flu. It's because it compresses a 3 to 4 month clinical event into about 3 to 4 weeks. And it has 2 to 3 times the severity of flu. And if you multiply those together very simply, you get something that's 8 to 12 times as bad as a crushing flu season. And that's, clearly what we saw clinically in terms of turning Weill Cornell into one big intensive care unit. So
I'm sorry,
how do
can
we
I
put
just
all
ask a
this
quick
information?
question? I apologize about that last slide.
Yeah.
You don't mention the fact that we also have treatments for flu, right? I mean, separate from the vaccine, putting that aside, severely hospitalized patients, there are antivirals that can be used that modify it, right? So is that included in some of your modeling in terms of understanding this? Because it's not just the compression and the novel, it's also the novelty of not having any treatment, right?
Right. So this is, I tried to be careful in the title of the slide, why it upends healthcare systems. What I'm really focusing on here is everything up to the point of treatment. So you're absolutely right that it's, in fact, it's much worse than flu because we don't have the ability, or we're just perhaps turning the corner on having the ability to spare people from both death and also really critical long-term hospitalizations. But even if you take that away, even if we had those treatments, it would still have upended healthcare systems simply because of the volume. And this is what I'm trying to, the volume of severe patients coming in the door. So you're absolutely right. That just makes it even worse. So it's 8 to 12 times the volume of critical patients arriving, plus the fact that we can't do anything about most of them still, and the fact that when they get critically ill, they wind up requiring massive amounts of hospital resources. So I completely agree with you. And I could make a second slide saying, and it gets worse from here. So lots of information so far. I know I want to be respectful of your time. You all have to start your day jobs in about 15 minutes, but I do want to get to the fun stuff in terms of the modeling. So it turned out that during February and March, I got in touch with a colleague who I had met actually a year before. We had been trying to put together an international project for developing modeling and analytics capability within ministries of health in low and middle income countries. And so Lisa had a respiratory syncytial virus modeling project with her friend and colleague Pan, Richta Panun from the Thailand Ministry of Health. We put this together. It was an R-based model, and we started creating some output. And this is when I started working with Governor Cuomo's team. And so we were able to show in the blue here, for example, what we thought might be an unmitigated curve, and then in the orange and in the gray, interventions. And so we looked at school closure, hand washing, and this, of course, March 16th is the day that schools closed and before the governor announced the lockdown. And so we started doing all sorts of interesting things, and we looked at what might be the hospitalizations if we did nothing. So that would be 142,000 across the state, and 21,000 ICU and 9,000 ventilators. So numbers like this helped to buttress the request for increased numbers of ventilators. And then we looked at things like these curves, which were the mitigated curves. And you can see that we were really off by a lot, because look at the x-axis. We were talking about mid-June. And this was, again, the old paradigm, the slower, wider wave. we eventually did create this international collaborative on the basis of this model. So you can see in blue all the countries that are now partnered to the collaborative. It's called the Como Collaborative. These are many of the individuals who are involved, several from the US. Personally, I'm working with Dan Fitzgerald, who's from our Global Health Department, and Jean Pape in Haiti using this model, and there are others using it all around the world. And the modeling interface is quite beautiful. This is created by both Ricardo Aguas and Olivier Selhe. Those are the fourth and third from the end there. And you can see that you can implement different types of non-pharmaceutical interventions. You can upload real data. And the model actually has, as part of its engine, the Cornell C5V model. It's a complex mathematical model. This is just part of it. It also involves, as I mentioned, lots of inputs. These are all difficult to find and even harder to accurately parameterize. But if you can do that, then you can start experimenting. And so instead of using the 1.3 to 1.5% prevalence infection and hospitalization rate, I decided to, in the next set of slides, to be even more cautious and just use a 2% hospitalization rate. And that assumes just that there's 21.5% prevalence of infection in New York. Even if you just make that assumption, you can actually fit this data pretty easily, both using interventions like this picture and also no interventions like this picture. It just depends on how you want to parameterize the model. You can see the red is the hospitalization, the green is the estimate that the model makes of the hospitalization. You can even tune the model so that it not only accounts for the observed deaths, but also these additional deaths. And you can change the parameters. You can just see, I'm not going to go through all of it because we don't have much time, but you can see that you can match the deaths, you can not match the deaths, you can have interventions, you can not have interventions. If you drill down, you can get numbers that look roughly like this. So here you see a run of this model that's fit to New York City data that states that in the end, at the end of this all, about 70% of the city is going to be infected with about 23,000 deaths. Now, I don't want anyone to focus on those two numbers. This is just one run of a model. This is looking like a painting and picking out one pixel. You don't want to make a conclusion about what the painting shows on the basis of one pixel. But this is just to show you that if you then take away those, so here's all the interventions that we believe are currently in place: self-isolation, social distancing, hand washing, working at home, school closures, and we get 23,000. If you take those all away, it's interesting. You don't really have much of a difference. You have an increase in the percentage of people in the city by about 10% who are infected, but you only have 400 more deaths. And why might that be? Well, a lot of people think that that's because the interventions were started so late in the day, essentially just as the curve was reaching its peak. And so you can change some things around. So here I've got a slightly different set of things, including a travel ban. So we have 0.1 infected migrants coming into, and when I say migrants, that just means someone coming into the city from outside, coming into the city starting on the 7th of January. And so if we lift all those, we see a slightly different effect. We see a little bit more of an effect of lifting. And so that had a 61% overall infection rate to start with. You can see how these pictures of what's happening from the lockdown to the non-lockdown actually make empirical sense. And then what's nice about this model is that you can dive under the hood and see who's actually most impacted. And one of the things that I want you to take away is that this brown is all greater than or equal to 70 years old. And so this is a common finding now in models. And in fact, if you look at The Guardian and other papers, this is now a headline that we sort of forgot over the last couple of months that the people being most impacted by this are, for example, individuals in nursing homes. The output of this model includes information about hospitalization. It includes this famous number, the reproductive number, where it starts out a little bit above 2 and then drops down in the case where you have interventions. Interesting enough, it does almost the same thing with a bit more of a drop when you don't have any interventions. And so again, this is indicating that the interventions that were put in place may have had some effect, but may not have had as much of an effect as either we would have liked or that people give them credit for. So what's missing from all of these models? One critical thing is the inability to distinguish individuals in the general population from individuals in very specific high-risk areas. So for example, we now know that these processing facilities where perhaps due to the high level of aerosols and inability to physically distance yourself from your coworker, there are a lot of cases going on. Prisons as well, major focus of outbreaks in the US. And now, of course, nursing homes. And we're actually involved with folks in New Jersey looking at this. I'm going to skip over this slide because we don't really have much time. Getting back to New York, you can see that in this animation that was provided by our engineering colleagues from Ithaca, we really have focal outbreaks about which we don't quite know all the details. And so it's just another piece of information to suggest that we model whole cities or whole countries at our peril. And the peril is that we don't really get from the model information that we need to control these complex situations, which was the point of the last slide. This was a project, again, by my great former colleague, Babak Porbalal, and actually a Cornell undergrad, where they took the same hypothetical flu and dropped it into different Canadian cities, varying only the commuting patterns of the cities. So you can see Toronto, very centralized because a lot of use of mass transit, versus Calgary, very decentralized because basically everyone drives their own car. What they found was that if you drop the same flu with the same original reproductive number, that's the R0 or the R0 that modelers talk about, into these different cities, you actually get very different outbreaks with very different effective reproductive numbers. And so it's just yet another piece of information to suggest that if we don't really get more detailed understanding of where the virus is and how it's spreading, we may miss a lot about what's going on. So with my colleagues, Justin and Alex, the mathematicians, we've been looking carefully, for example, borough by borough, at the free and public information on influenza-like illness from our syndromic surveillance, breaking it down by age. For example, you can see the purple is this aberrant signal from COVID spanning age groups and affecting them really differently. You can see that the young individuals, almost citywide, but really much more in the Bronx and in Queens, had outbreaks that way, and you can tell that because the scales on the y-axis are different, had early outbreaks in young individuals. And in fact, you can see as you go up in the age categories, this outbreak is marching slowly day by day through the age categories. And so we really don't know enough about that to make much sense of it at this point. Because of all of that, I really caution modelers and others, and this was actually part of my day job at CDC and part of my job as an advisor for the MIDAS modeling program. I caution people about drawing conclusions either from data or from models. And unfortunately, Dr. Mitch Katz, who's really been doing a great job leading Health and Hospitals Corporation, had this very unfortunate quotation in the Times back on the 14th of March saying, Wuhan got over it and they did everything wrong and New York City will come out of this better, certainly better than Wuhan. I mean, it's one of these famously incorrect statements when you look at it with 20/20 hindsight. So in conclusion, one of the key things I've learned from working with our great engineering colleagues upstate is this quotation from Jack Muckstad, who is now emeritus professor in operations research. The purpose of the model is to understand the problem. Many people misrepresent the purpose of models as to get a crystal ball-like projection of the future, and I really believe that that's not the case. So here are some tentative conclusions. If any of you saw the medical grand rounds a couple of weeks ago, I had a slightly more forceful conclusion, and I think I've tempered it a little bit as I've been messing around with the models, trying to figure out if I can generate a second wave. It turns out that it's very difficult, given the data that we have, the actual track of the infection in New York City. It's very difficult to imagine a scenario in which we have a major second wave. And that's simply because so many people got infected in the first wave. So the models, I'll read this, the models for New York City, parameterized to recent seroprevalence results and assuming durable immunity, which increasing evidence suggests that we should, suggest that there may be no large second or subsequent waves in 2020 due to a lack of remaining susceptibles in the city population. However, this absolutely does not mean no continued transmission, as the data that I showed at the very beginning suggest. I mean, New York City is still having more deaths than most other cities in the world. There will certainly be continued cases as the virus finds pockets of old, formerly shielded, for example, at nursing homes or other care facilities, or new individuals coming in. Tourists is a big issue. A lot of colleges in the city have been asking me about what the projections might be for students, for example, returning from other parts of the world. The third bullet here is that COVID is a complex phenomenon. We don't need to fully understand complex phenomena for us to be able to control them. But if we don't address the fact that it's a complex phenomenon, we certainly will miss things. So focusing control efforts on places of increasing importance may be most effective. I know that we now in the city have this mass contact tracing and tracking system that's gaining shape, but I'm not sure that that's the best expenditure of effort, because we know on the basis of the last couple of months where this is most likely to have its worst effect, and it's not in the general public. And in fact, we have a paper now that we're working on with New Jersey that shows really two pandemics, one in the general population that, at least in New Jersey, is improving, and one in long-term care facilities in that state that is really not improving. So I just wanted to finish off by acknowledging my colleagues, again, Lisa and Ricardo especially, and then the team with the Cornell caseload calculator. And I've got pictures of two of our great first-year medical students, Lior and Rouge, and they've independently created a freestanding Python-based version of this that's going to go up on our website really soon. Art Evans of the hospital service, Monica, the head of general medicine, have been absolutely incredible in leading both the clinical and the research efforts. And then my colleague, Robert Gugeli, I wanted to acknowledge as well. He's a long-term emergency preparedness professional who's been helping out a lot in thinking through all this. And that's it. So I'm happy to take some questions. Yep, I think we have 1 minute.
Nate, that was great. I don't know if can you hear me? Just want to make sure I'm not on mute.
Yeah, absolutely. Yep.
Yes. So just so I understand, it was obviously complex and beautifully presented. What you're saying is that quarantines work if they're done early, and that in New York, it was really started way too late, and that the quarantine perhaps has not been as effective as we would have thought. And correct me if I'm wrong, because I'm sure I am. And that we probably should lift the quarantine because it's not going to do that much good anymore, which is not really what we're doing, and maybe is politically not a popular perspective. Is that a correct takeaway from this? Because everyone's been infected to the degree they have, as you said, that maybe continuing this quarantine is not really making as much of a difference as we think.
I'm definitely in the camp that the lockdown in New York City is probably no longer having the effect that the people who put it in place think it's having. Again, if we completely reversed everything today, if we just let people walk around with no face masks, we definitely have more cases. But I don't think that we would have the surge of cases that either is occurring in other countries that didn't have such bad initial outbreaks, or that that people fear would occur and would impact hospital capacity, for example. It takes a certain fraction of the susceptible population to sustain ongoing transmission and to bring that reproductive number back above 1. As I said, it's really hard to come up with a scenario, given what we know already about how many people, or what we assume we know about how many people in New York have been infected. It's really hard to sustain that second wave. And so the unfortunate thing is that, yes, this has become unbelievably politicized. But the point that we're going to try to make in this paper with New Jersey is we can't even really begin to talk about this unless we take all these models that have been unitary and at least split them in two, so that we have a long-term care model and a community model. And really, if you look at the community model, even in a place like New Jersey, which lagged New York, you know, there are many zip codes in New Jersey with no cases in the community. And I'm sure that if we looked, you know, through the 42 United Hospital Fund neighborhoods in New York, I'm sure we would find neighborhoods that haven't yet had bad outbreaks and so should be targeted for enhanced monitoring, but neighborhoods that have had terrible outbreaks and so, you know, perhaps are done. This is all work that needs to be done still. But I think the bottom line is, yeah, it's for New York City, we're really unusual globally in terms of the outbreak that we had. You know, we led the world in the wrong way. But the potential flip side of that is that we will not have as much of a concern, I believe, based on the modeling, as other cities and other countries will for second waves.
Nathaniel, it's Phil Steig.
Yeah.
Great talk. Really appreciate you putting this together for us. Two questions. I noticed that Staten Island didn't have even close to any spike. Number one question, any thoughts on that? And number two, as we sit in meetings and listen to the governor stating that we can't expand, we have to have at least 30% capacity in our ICUs for the quote second wave. Is that a reasonable, or what would you propose?
So I can answer the first question pretty easily. Staten Island actually had a very unusual, this is really why we have to model this borough by borough. Staten Island had its own course. We think that part of it is that a lot of people who live on Staten Island are essential workers, and so they couldn't lock down. And so they had some initial infection and then a bit of a later spike. It really had its own path. You know, Queens was early, Bronx was second, Brooklyn next. Bronx sort of acted a little bit like Upper Manhattan and a little bit like Queens. But Staten Island, because of its geographic distinction from the rest of the city, does sort of act independently. On a population basis, though, it wound up having a pretty bad outbreak, and certainly worse than many swaths of Manhattan, which really is the laggard in all of this, which raises questions about, you know, second wave type phenomena for the Upper West Side, the Upper East Side, and other areas of Manhattan that were a little bit protected. The second question about what the governor has been asking hospitals to do, it's very, very tricky for me, partly because I am a volunteer in advising the governor. I personally have not been part of that request for 30%. I was more a part of the initial request, which I do think turned out to be, you know, asking for more than we needed, but we didn't know that at the time. I am currently, I can let you know, I'm currently, as of last week, modeling all 10 economic regions of the state for the governor's team. And hopefully out of that, I'll be able to make some recommendations about what an evidence-based number would look like. And I can assure you that based on the modeling so far, that it's not going to be that much in New York City, and probably it's not going to be that much in most parts of the state. Because again, one question is, what happens if we see anything like the number of tourists that we had historically? I mean, that may just never happen again, at least not for many years. But if we did, it's possible that we could wind up with wards full of people coming into New York from Asia, where they were much more successful in certain areas like Singapore in tamping down that first wave. So I think it's still an open story, and I look forward to bringing you some follow-up.
Could I ask one additional question? This is Ben Rappaport. I'm one of the residents.
Yeah.
Thank you for a fascinating talk and for sharing your work and insight. I wanted to ask two related questions, maybe summarized by the question of error bars and generative models, both of which you kind of allude to in the talk at various points. By error bars, I mean some of the modeling efforts early on that you describe and others have shown are kind of oriented towards curve fitting to data as they emerge, and those seem to be prone to certain kinds of error. And related to that, you kind of at the end start talking about using models to understand the epidemic, and one might think that generative models that explain from sort of first principles how the epidemic behaves might help us understand things like what you're describing, how the long-term behavior changes, what the epidemic looks like in different parts of the state or in different countries, how we use a model to understand what's going on in one place versus another, and that might give us some confidence that we really understand what's going on. I wonder if you could comment on those two things.
Yeah, great questions. So let me just take a broad stab at error bars in models. I find it very misleading typically when modelers talk about confidence intervals about their models, because really that is assuming that the model is, as you mentioned, proper in terms of its generation of the data. I think, especially given the time, let me just give you an analogous situation. We did not understand what was going on in 2014 with Ebola, really until the modelers started taking into account the fact that dead bodies were major sources of transmission, and that funeral activities, or really a kind of sociological investigation into how funerals were conducted in West Africa before and during the Ebola outbreak led to wholesale changes in how the underlying model structure worked.
But isn't that precisely right? Like that you want to be able to not just estimate the error intrinsic to the model, but rather to get some estimate of how wrong the model might be.
Right. So we're working on that now. And you take IHME, that's the Gates funded model. They've already had 3 or 4 major revisions of how their model worked, mostly because everyone immediately criticized it for taking a Wuhan shaped hammer and whacking everything that looked like COVID with it and saying, oh, it should turn out this way. That was obviously, I mean, they actually literally called their model a curve fitting tool and not a model, because it did not have anything more than this should look like Wuhan type of form to it. So what do we do now? I think the most important thing is to understand the dynamics of the disease in these locations where people are at the mercy of others for their health and safety and basically for their life. And this would stretch from long-term care facilities to prisons, especially, which, as some of you who've been following the Times know, have been responsible for some of the most intense outbreaks. For example, Marion, Ohio, most intense outbreaks of COVID in the US. And then onto these places like slaughterhouses, where I'm sure we'll find that part of the reason why they were such intense foci of infection is because of the fact that you can actually get aerosolization of this virus when it hops onto small particulate matter like PM2.5, which raises other questions about long-term health and safety in places like New York City, where if you look at the PM2.5 maps of the city, most of Manhattan has much more intense particulate matter pollution than other parts of the boroughs, which raises other questions about why some of those places were and not Manhattan were the sources of the first outbreaks. And that's probably actually due to indoor pollution. And so there are all sorts of difficult and squirrely things that we're going to have to figure out before we can get accurate models of what actually happened. I will only be happy with my models when I can explain really neighborhood by neighborhood why the outbreak occurred the way it did in New York City. And I think that'll take a lot of work.
Nate, that was fantastic. I'm sure we could go on all day because of the timeliness of this talk, but we have other things going on.
Great.
So I think we probably should cut it off later. I'm sure people could send you an email or two if they have some specific questions.
Absolutely.
And then
Please
you can answer
yeah.
them at your leisure when you have time. Thank you again. This was wonderful.
Okay.
And thanks for taking the time.
Thanks, Ted. And thank you all for your time. Talk to you soon.
Great. We're going to have Journal Club to follow. Thanks so much.
Okay, great.
Bye.
Great.